Let's start the session. I would like to welcome and chairperson and judges, Dr. Santosh Mahapatra. A very good morning, sir. Dr. Shweta Walia, Dr. Prasad Valambe.
Namaste.
Namaste, sir. Dr. Suma Ganesh.
Namaste.
Dr. Kalpana Narendran. A very good morning, sir. Dr. Nikhil Rishikeshi. A very good morning to all the chairpersons and judges. I would like to welcome the first presenter, Dr. Poonam Rawat. Ma'am, can I request you to please share your screen and start your presentation? We have said that.
Sure.
Can we have the timer on the screen, please?
Am I visible?
You are visible. Slides are not.
Okay. So, Lionel, you can wait for one more judge. Without two judges, we cannot start the session. You can.
I'm not able to share my screen. It seems the host has disabled the screen sharing. Kindly check.
Dr. Partha, I am Dr. Shweta Singh, Shweta Walia. I was also judge in this session and I have joined.
A very good morning, ma'am. Welcome to the first session.
Please make it slideshow.
Yes, sir.
Can start a timer now.
Shall I start?
Yes, ma'am.
Good morning, everyone. I'm going to speak on influence of refractive error on retinal and choroidal thickness in children with amblyopia. As we know, visual deprivation during neonatal period negatively affects the growth of cell in lateral geniculate body, and it causes corresponding changes in the visual cortex. This has retrograde influence on the retinal as well as the choroidal thickness. So the aim of this study was to determine these thicknesses in amblyopic eyes and to see if refractive error has any influence on these parameters. We had taken children up to the age of 12 years. 50 cases of unilateral anisometropic amblyopia were taken, that is 37 anisohyperopes and 13 anisomyopes. And 3 control groups were there, internal controls, that is fellow uninvolved eye. 50 external controls were there, that is children with refractive error with BCVA of 6.6, and 50 emetropes were taken. Any history of intraocular surgery or ocular pathology were excluded. Other forms of amblyopia were excluded from this study. Coming to methodology, all children underwent comprehensive ophthalmic examination, and a spectral domain OCT was used to study the various thicknesses. Evaluation of macular thickness was done in all the 9 macular ETDRS subfields. RNFL thickness overall it was taken, and choroidal thickness was measured with the help of inbuilt caliper manually. Coming to discussion, the mean central macular thickness in anisohyperope was observed to be significantly thicker than the fellow eyes and emetropes. However, no significant difference was seen between anisomyopes and control groups. Coming to mean RNFL thickness, there was no statistical difference between anisohyperopes and the control group, whereas there was significant thinning in anisomyopes as compared to external control myopes and emetropes. The average subfoveal choroidal thickness, it was seen to be significantly thicker in anisohyperope as compared to the control groups, and there was no such difference seen between anisomyopes and the control group. So to conclude, in anisohyperopes, there was significant thickening in the central macular area and the subfoveal choroid thickness. However, there was no impact in the peripapillary RNFL thickness. And in anisomyopes, there was significant thinning in the mean peripapillary RNFL thickness. However, in macular thickness and subfoveal choroid, there was no statistical difference seen as compared to the control groups. So this study also provides a valid normative database of these parameters in Indian children with and without refractive errors, which can be used in the future reference if further studies in the larger subjects will be done. Thank you.
So, Dr. Shweta, Please unshare your screen so that we can discuss and ask questions. How do you measure the choroidal thickness in each case, and how you ensure that it is a similar point on which you measure the choroidal thickness in different children?
So, sir, we have taken retinal cross line and in the chorioretinal mode, so that mode the choroidal vessels are more clear. And in the view mode, there was this inbuilt caliper. We had taken we have measured from the posterior aspect of the retinal pigment epithelium till the choroid and scleral junction. So there was two borders which was made, and the thickness was manually measured with the help of inbuilt calipers.
So then, how do you ensure that it is on the same point in each patient?
We have seen the hyperreflective layer, that is RP posterior layer, as well as.
No, you are not understanding my question. My question is, when you are going to compare the choroidal thickness, you need to ensure that you are measuring at the same anatomical point on which you are measuring. How do you ensure that? Some patients have a
yes, a sub.
Where it detects the same anatomical point. But in SDOCT, I don't think.
Sir, it was measured by the same observer. I have manually measured all the thicknesses myself.
Cannot ensure the same point of measurement in different.
Yes.
Any other questions?
Any other questions? Shall we move on to the next presenter?
Yes.
Yes, okay. Now I would like to welcome Dr. Shweta Vishwanath. Ma'am, can I request you to please come on screen and share your
Yes.
presentation?
Just a second.
Yes.
Is my screen visible?
Yes, ma'am.
Okay, shall I start?
Yes.
Okay. Good morning to one and all. I'll be speaking today about the role of 0.01% atropine eye drops in the control of myopia progression in children. I have no financial interest to disclose. The uncorrected myopia is a leading cause of vision impairment and an important cause of preventable blindness, especially in a developing country like ours. According to a study conducted from Delhi in 2015, the prevalence of myopia is 13.1% among the school-going children, which was much higher than the previous reports. This indicates that myopia is a growing public health problem, which has a huge social, educational, as well as economical implication. Various treatment modalities have been used over the years for the control of myopia progression, which includes corrective modalities like spectacles, contact lenses, behavioral changes like a decrease in the amount of near work, increase in the outdoor activity, and various pharmacological agents like atropine, pyrazipine have been used. Recently, atropine drops have been globally used to prevent the progression. However, 0.01% drops have been most commonly used because of its minimal side effects.
DNA and then PRN.
In our
The
randomized
PCV was almost similar both the groups.
We had a sample size of 60 eyes. The study was conducted in myopic children of 6 to 16 years, attending the outpatient department of Guru Nanak Eye Center, New Delhi. We divided these 60 eyes into two groups equally. Group A receiving 0.01% drops and atropine drops, and Group B receiving artificial tear drops. Now, the children had myopia of -2 diopters to -6 diopters with a best corrected visual acuity of at least 6/12 with a stable astigmatism of less than 1.5. The children with best corrected visual acuity less than 6/12 were excluded. Other exclusion factors were strabismus, ocular hypertension, glaucoma, amblyopia, allergic reaction to atropine, pathological myopia, lack of consent, and any ocular pathologies. Now, during the first visit, we measured the following parameters: the uncorrected visual acuity, best corrected visual acuity, the power of glass, refraction, spherical equivalent was measured using refraction, which was done by HA 2%. Hirschberg test was done to rule out any strabismus. Pupil size, axial length was measured using lens star, and the near point of accommodation measured using the Royal Air Force ruler. The primary outcome in our case was change in the spherical equivalent with respective to the baseline and change in the axial length. Also, we wanted to note any side effects of the atropine eye drops if present. Now, coming to the result, we observed a mean progression of spherical equivalent at the end of 12 months. There was a reduction of progression of myopia in the treatment group of about 47.5% as compared to the placebo group. And also in the axial length, there was, at the end of 12 months, there was a decrease in the progression by 48.38% in the treatment group as compared to the control group. Now, this finding of us also corroborated with the study of ATOM2 LAMP study at 1 year, and similar progression was also noted by Jitani et al. But an interesting thing here is that in our study, the axial length also reduced, also showed a marked decrease in the progression as compared to the other studies where only spherical equivalent was reduced. These are the other studies. Now we conclude that atropine eye drops is effective in reducing the progression of myopia with minimal side effects, like there was no change in the pupil size, with normal near and distant vision as well in the patient using the drops. Also, the amplitude of accommodation also remained.
Time's up. Please conclude.
Yes, sir. Thank you, sir.
We can have questions.
Yes, yes. Any questions?
Yeah, just one question. Some of the other confounding factors, for example, the strong family history of myopia or outdoor activities or screen time, have you taken into consideration these factors? Because there was just only atropine. That was the only factor which is considered.
Yes, sir. So primarily, we had taken just the school-going children, but the family history was taken, but there was no significant family history in these children. So.
Okay, and amount of screen time, amount of outdoor activities?
No, sir, that was not assessed.
Okay.
What is the cutoff limit for your, like you excluded pathological myopia?
Yes, sir. So, firstly, we included myopia of less than -6 diopters, and also on fundus examination, any pathological change was excluded, sir.
What is the minimum follow-up period?
Sir, we followed up a patient for the period of 12 months, sir, 1 year. They were followed up every 3 monthly for a period of 12 months.
Any accommodation anomalies did you see in any of the children? Like you had studied that factor also, no?
Yes, ma'am. There was no significant change in accommodation. There was no there was no decrease in amplitude of accommodation after the use of drugs.
Are there any papers which document some of the side effects of atropine?
Sir, there have been, but it has been increased, like atropine concentration of 1% have been documented.
No, 0.01%. Are you aware of any of these side effects which have been published in peer-reviewed journals?
There have been no significant side effects with 0.01%.
Okay.
And now we can go to the next.
Thank you.
Thank you so much, Dr. Shweta Vishwanath. Moving on to the next presenter, I would like to welcome Dr. Deepa Chitra. Ma'am, if you are here with us, can you please share your screen? Okay, I think she's absent. Moving on to the next presenter, I would like to welcome Dr. Bindya C. Ma'am, can I request you to please share your screen and turn on your camera?
Yes, ma'am.
Yes, thank you so much, ma'am.
Um, uh, 1 minute. Um, uh, Good morning. So my study is about awareness of ROP among ophthalmologists and pediatricians in South India. So previous literature search, it showed that the awareness among pediatricians showed contradictory results, and there are no studies assessing ROP awareness among ophthalmologists. So coming to the material and methods, it was a cross-sectional study done over 1.5 years, including equal number of pediatricians and ophthalmologists. We included pediatricians and ophthalmologists in Pondicherry and surrounding districts of Tamil Nadu, and we excluded the participants who are not willing to give an informed written consent. A pre-validated questionnaire was taken from a similar study and was modified for use in the study, and we took informed written consent from everybody. So there was 25 questions in the questionnaire, which assessed one.
Vindhya, your slides are not moving.
Hello. Oh, okay. Slides are not moving.
Dr. Santosh, is it moving or is it my computer?
No, it is not moving.
Not moving.
It is not moving. It's the first slide which I am seeing.
Check. I thought maybe it's my computer. That's why.
Oh, his slides are not moving. Just 1 minute, ma'am.
You can
Hello.
stop computing the time till that time.
Good morning, sir. Every presenter open the PPT first, then when her or his turn, then share the PPT.
Hello.
Just try again now.
Ma'am, can you please try once again to reshare your screen?
To try again.
Just open the presentation and
Yes,
then
sir.
share.
First, I should open the slides. Okay, sir. Sir, can I present as the next? There is some problem with the laptop connectivity.
Come back to her later.
Yes, sir, you can continue with the next presenter, please. I will be back within 5 minutes, sir, if it is possible.
Okay, if the who's the person who's anchoring the session allows it.
Yes, ma'am.
She wants to come after some time.
No problem, ma'am. I will just be.
So we can call the next presenter, I think.
Yes, we can invite the next presenter.
Thank you. Thank you so much. Thank you so much, sir.
Thank you, Dr. Bindya. Moving on to the next, I would like to call Dr. Yushi Sao. Yes, she's with us.
Hello. Good morning, everyone. Is my screen visible?
Yes.
So to make it a slideshow.
Good morning, everyone. So I'm presenting a case of Warburg microsyndrome. It is a congenital cataract with microcornea and deprivational amblyopia with developmental delay and polymicrogyria. A 1-year-old female presented with white reflex in both eyes, born of second-degree consanguineous marriage after full-term normal delivery. She had NICU admission for 3 days for refusal to feed and was immunized till day. The child had recurrent tonic seizures with eye uprolling and history of repeated URTI and LRTI. On examination, the child had microcephaly, spastic quadriplegia, incomplete head control, facial dysmorphism, and immature palmar crust. On ocular examination, she had bilateral congenital cataract and microcornea with corneal diameter of 8 mm in both eyes. The pupil was atonic, and fundus examination was not possible. The intraocular pressure was 11 mmHg and B scan was normal. On investigation, the torch testing was negative. MRI showed bilateral frontal and parietal polymicrogyria, and corpus callosum was well developed. The child underwent pars plana lensectomy under general anesthesia and is undergoing physiotherapy. And the parents were advised for non-invasive prenatal testing, genetic counseling for further pregnancy, karyotyping, and amniocentesis. So Warburg microsyndrome is a rare genetic disorder with less than 100 cases reported and only 2 previous cases from India. There are alterations in RAB18 gene and patient present with microphthalmia, microcornea, congenital cataract, usually affecting both eye and optic atrophy. Patient also have severe intellectual disability and developmental delays and seizures. The abnormality of brain development include polymicrogyria and hyperplasia of corpus callosum. An infant will also exhibit growth failure and hypotony. So in conclusion, the ophthalmologists play a crucial role in diagnosing such rare cases where the presenting complaint is a wide reflex. Early diagnosis in such case help in prevention of amblyopia. These are the differential diagnosis. Patient's consent was consent of the parents were taken, and there is no financial interest. These are my references. Thank you.
Well documented case. How do you confirm your diagnosis on clinical basis only, or have you done genetic testing?
So only clinical basis, and the main thing was MRI that it had polymicrogyria along with bilateral congenital cataract. So I have not done genetic testing. The patients were not affording, but I did advise them.
What prompted you to do the MRI? And second question is, what are the different anesthetic considerations when the patient is taken for the surgery in view of this syndrome?
Yes, sir. So also because the patient was having recurrent seizures and general tonic seizures, so that's what prompted for MRI. And
was it advised by pediatrician or yourself?
Sir, by pediatrician. First, they presented to us. We took a reference with pediatrician, and then MRI was taken. Then polymicrogyria came. And for such patients, when you are taking for general anesthesias, especially intubation difficulty will be there. We should also rule out such cases from Rutledge syndrome and do a chest X-ray. There might be difficulty in extubation in such patients.
And usually the anesthetists prefer a tube or a LMA.
Sir, in this case, they did under short GA, sir.
LMA is lower mask, laryngeal airway mask.
Yes, sir.
But do you prefer LMA over a tube in such patients? Are you aware of any anesthetic implications of such syndrome?
Sir, I think LMA is preferred because of the micrognathia might also be occurring because of the facial dysmorphism.
Okay, very good. Well documented case.
Any other questions?
Any more questions? We may proceed then. Now I would like to welcome Dr. Chandni Chakrabarti. Ma'am, can I request you to please camera and share your screen? A very good morning, ma'am.
Can I start? Am I audible?
Yes, ma'am.
Please go ahead. Yeah.
Good morning, the respected judges and the chairpersons. COVID-19 pandemic has induced tremendous change in our lifestyles. So my present study is to look into the eye health related behaviors of urban school children during this lockdown. I have no financial interest in this presentation. COVID-19 pandemic has changed our educational system tremendously, and the present study is to analyze the impact on ocular health related behavior. So the expected sequence of incidences are reduced outdoor activities and increased screen time, causing myopia progression, digital eye strain, accommodative anomalies, and convergence anomalies. Now, it is a prospective observational study where the parents of urban school children up to the 18 years of age who had provision of online classes were included. And the blind school students, differently abled students, children not enrolled in school, and absence of online class facilities were excluded from the study. And the mode of collection of data was online questionnaire. So the first obstacle we faced was the very poor response rate. That was only 39%. 36 out of 92 sets of parents responded. So out of these responders, 50% of the kids were using glasses before the lockdown, and other eye problems were present in 22% of the kids. Now, so far as the outdoor activity was concerned, we got a mixed response. In 44% of the patients, outdoor activity was decreased, and 50% have same amount of outdoor activity, and in 6% of the patients, it was increased surprisingly, maybe because of the reduced school time and standalone houses. And so far as the screen time was concerned, it was a very high incidence of increased in screen time, more than 1.5 fold. It is 69%. Now, before the lockdown, 11% of the students reported difficulty in doing physical classes for seeing the online, for seeing the board writings, and during the online classes, 14% of the students had some difficulty and eye strain during online classes. Only symptoms we encountered were asthenopia, and it was present in only in the patients with screen time increased. That is, there was a high percentage, 20% of the patients developed asthenopia, but the screen time was increased. And out of the asthenopic patients, all were having more than two-fold increase in screen time. So, no new eye problem except asthenopia developed during 6 weeks of lockdown. It was a very short period of follow-up. Then a significant incident of asthenopia, 20% associated within this short period. So, it is very alarming. And during the post-lockdown children's eye clinic, we got some other problems like accommodative spasm, lag, then acute comitant dysotropia, breakthrough myopia in kids with atropine therapy, new myopia in older children, dry eye, and allergic issues. So adequate counseling about the eye health practices on first contact may help to prevent this type of problems. The limitations of my study are small sample size and the short follow-up period. But lockdown and online classes related to COVID-19 pandemic has immense impact on the ocular and visual health of and health-related behavior among the kids. And extensive public awareness must be generated on health-related kids. So I am using my YouTube channel for this awareness. These are my references. Thank you. Stay safe.
Dr. Chandni,
Yes, ma'am.
I have a question for you.
Yes.
Were the patients who had asthenopia, they were called and reviewed in clinic?
After the lockdown, they were called, but during my study period, I could not call them.
So, what ocular pathology or refractive error you found in those asthenopic patients?
I got few patients with accommodative lag. Accommodative facility was reduced, and the patient, after concentrating on the screen, they developed some problem in seeing the distant object. There was some blurring of the distant objects. So this was one problem, and also I got the increase in minus power, that is myopia, in some of the kids. So these are the main two problems I got. Other problems like accommodative spasm and acute comitant dysotropia, I got in 1 or 2 patients only.
Yeah, Dr. Chandani, one more question.
Yes,
So a good topic. The couple of questions. How did you validate your questionnaire? Number one, and number two, there are of course some reports of accommodative problems in adult population. But have you asked about COVID positive status or not? Because those children who are COVID positive are definitely going to have some accommodative problems. So we have to differentiate between COVID positive and negative.
All of these children were COVID negative, sir.
Did you ask about their status of COVID?
Yes,
In
yes.
your questionnaire? Okay, good. And how did you validate your questionnaire?
Validate means there was a very short time, sir. After March 31, the lockdown started and I had to submit. So I just administered the questionnaire only.
Okay. Okay. You didn't show your questionnaire also, that's why.
Yeah.
Okay, but
okay. If there's no other question, you can move to the next speaker.
Sure.
Yes. Okay, so now I would like to welcome Dr. Surbhi Khurana. Good morning, ma'am.
Good morning.
Please share your screen. And turn on your camera, ma'am.
Yes. I'm not able to turn on my camera. Just a second.
No problem.
Okay. So I'll share my screen then.
If that's okay with the chairperson and the judge.
No problem.
It's okay.
Okay. There's some.
We need to know who the presenter is, as the presence of speaker is must.
Ma'am, I'm trying to. It's actually showing some browser-related problem.
Everybody should at least on their camera.
Yes, actually, it's showing some browser-related problems. So yeah, so if you could move to the next one, I'll just reset it again.
You start. It's okay.
Okay.
We are already one speaker.
Okay. So my topic is surgical and visual outcomes of congenital cataract. So the aim of study was to evaluate the presenting features, surgical and visual outcomes in eyes with congenital cataract operated in the first year of life. So it was a retrospective study where review of surgical records for unilateral and bilateral cataract were taken who were operated in their first year of life. And surgery was phacoaspiration with primary posterior capsulotomy and anterior vitrectomy with or without IOL implantation. The minimum follow-up taken was 3 months and total follow-up taken was 2 years. Preoperatively, thorough systemic and family history was taken with the dilated slit lamp examination. Ultrasonography, A and B scan was done for all the patients and examination under anesthesia before surgery was done in all the patients. Patients with corneal diameter less than 9.5 and axial length less than 17 were left aphakic, and IOL power calculation was done according to Dahan's guidelines using axial length or after 20% undercorrection. Post-operatively, patients were started on topical steroids with antibiotic and homatropine, followed by retinoscopy at 2 weeks and amblyopia therapy. Frequent follow-ups were done with frequent examination under anesthesia, and second eye was operated within 1 to 2 weeks. Bilateral cataract was more common in our study with 50 seen in 50 patients, that is 100 eyes, and 21 females. Age of presentation varied from 2 weeks to 11 months and onset from birth to 11 months. The most common type of cataract seen in our study was zonular cataract, followed by white cataract and calcified cataract. And the most common systemic association seen was congenital rubella syndrome. Familial cataract was seen in 6 eyes. The most common symptom at the time of presentation was white reflex, followed by not able to follow light and deviation of eyes. Mean axial length was 18.78 millimeter with minimum aim of surgery as 4 weeks. IOL was implanted in 90 eyes and 27 eyes were left aphakic. And in 90 eyes, 84 eyes had in the bag IOL implantation and 3 in sulcus and 3 optic capture was done. We saw a decrease in the trend of retinoscopy in 2 years, and none of the eyes had myopic surprise, but 16 eyes had myopic shift, but IOL exchange was not done in any eye. Intraocular pressure, the change was not significant, but 6 eyes developed glaucoma requiring medical treatment. Membranectomy was required in 25 eyes and pupilloplasty was required in 11 eyes. In this, the difference between aphakic and pseudoaphakic eyes was not significant. Few IOL pigments were seen but should not require any intervention, and more than one resurgery was required in 16 eyes. None of our patients developed end-off, RD, or Thiasis bulbi, and difference between the complications in aphakic and pseudophakic eyes in our study was not significant. We saw nystagmus in 48 eyes, and CSM fixation was present in 40 eyes preoperatively and 79 eyes after 2 years. So what we saw was that the CSM fixation improved from 40 eyes to 79 eyes in 2 years, showing the benefit of early cataract surgery and amblyopia therapy in these patients. A decrease in retinoscopy was found with time because of axillary elongation. There was no significant difference in the resurgery rates between the aphakic and pseudophakic eyes, hence showing IOL implantation as a safe option in infants. Repeated visual axis obscuration and glaucoma were the main complications which were seen postoperatively, hence warranting the need for long-term follow-up. The surgery, what we saw was that surgery for congenital cataract has favorable outcomes, and IOL implantation is a relatively safe option. But we need to follow up these children for long-term for glaucoma, visual axis obscuration, and counseling of parents preoperatively regarding the need for amblyopia therapy, surgeries, and lifelong follow-up is crucial. Thank you.
Dr. Surabhi, why was the vision taken only CSM? Why not TAC or Cardiff or?
Ma'am, most of the patients were actually less than 1 year old, so we thought that CSM fixation is a very valid for less than 1 year old, a valid option. So that is why we took CSM fixation.
TAC or this should be done.
Yes, ma'am, that can also be done.
And you said a decrease in refraction. I mean, there should have been a trend showing what is the decrease in refractive.
Yes, ma'am, it was there. Yes, ma'am, there was I can show it again. Just a second.
Oh. How much was the decrease in refraction? Means how much did you undercorrect and how much was your decrease in refraction you saw in the first year?
Yes, ma'am, I'm sure.
That's a very valid point, no? If you have
yes, ma'am. And what we saw was that at average, it was 6.38 at 3 months, which decreased to 5.5 in 1 year, and at 2 years, it was 5.18. And the undercorrection we did was 20% undercorrection. So it came out as about 4 to 5 diopter in less than 1 year old, or the hand guidance, that is also 5 to 6 diopter target hyperopia in less than 1 year old children.
So you only had a 1 year follow-up, you mean?
Yeah, a 2 years follow-up, ma'am.
Yeah, were all the cases done by the single surgeon or there were different surgeons?
Single surgeon, sir.
Yeah. And second thing, did in each visit, did you measure the intraocular pressure by which method, or did you have to give anesthesia for that?
The intraocular pressure was measured every 3 months in the first 1 year, and every 6 months after 1 year, and was done in examination and anesthesia using Perkins.
Using Perkins.
Yes.
What was the IOL used, the intraocular lens? It was in the bag, or did you have to capture it, or what was the
Ma'am,
technique?
it was 90 eyes. In 90 eyes, we had implanted IOL. In few, there was single piece. In few, 3 piece. And in 84 eyes, it was in the bag IOL implantation with primary posterior capsulotomy. And in 3 eyes, we implanted in sulcus. In three, we had done posterior optic capture.
And what was the minimum age at which you had put the IOL in this particular study?
So after 4 weeks of age, not in less than 4 weeks. Thank you, sir. Thank you, sir.
Over, so we can move to the next speaker.
Yes. So next speaker in my schedule is Dr. Sahi Salgu. I think doctor is not present. Moving on to the next, I have Dr. Aruna Rahat Krishna.
What about Bindia? Bindia, so she left in between, no?
Yes. Okay, fine, ma'am. We'll ask Dr.
Yes, ma'am. I'm ready.
Yes. Okay.
So we are now going for the Bindia. Okay.
Yes, sir.
Sir, is the slides changing now, sir?
Yes. Please move.
Good morning. My topic for presentation is ROP awareness among ophthalmologists and pediatricians in South India. So while doing a literature search, it showed that among pediatricians, the awareness of ROP showed contradictory results, and there are no studies assessing ROP awareness among ophthalmologists. So coming to the material and methods, it was a cross-sectional study done over 1.5 years, and it included equal number of pediatricians and ophthalmologists. We included the pediatricians and ophthalmologists in Pondicherry and surrounding districts of Tamil Nadu and excluded those who are not willing to give an informed written consent. Pre-validated questionnaire was taken from a similar study and was modified for use in the study. So the questionnaire, it included 25 questions. It assessed 1, the knowledge, 2, the attitude, and 3, the practice profile of pediatricians and ophthalmologists. For assessing knowledge, we asked questions regarding risk factors, treatment modalities, screening guidelines, and composition and safety of dilatation drops. Attitude was assessed by investigating the beliefs of participants regarding ROP screening and barriers faced by them for referring the babies for ROP screening. The practice profile was assessed by asking questions regarding the mode and time of referral to the ophthalmologist. So coming to the results are also divided into knowledge, attitude, and practice profile of the doctors. So coming to the knowledge about the screening criteria, it showed that most of the participants knew about the time of screening, time of referral, and screening guidelines. The knowledge about risk factors was also pretty good. They knew about the risk factors of ROP like low birth weight, high oxygen, and prematurity. But unfortunately, 21.71% of pediatricians, they answered that low birth weight is not a risk factor of ROP. Now coming to the knowledge about dilatation drops, it was also, they knew about the composition and safety of dilatation drops. Regarding the treatment modalities, most of them knew about the treatment modalities like laser and anti-VEGF, but very few doctors knew about use of cryotherapy for treatment of ROP, and only 55.52% of doctors knew about the surgical treatment of ROP. Coming to the attitude of doctors, the pediatricians, most of them thought that the screening and treatment of ROP is safe and risk-free, but about more than half of the ophthalmologists believe that there are risks associated with the treatment modalities. And most of the doctors, they told that non-availability of ophthalmologists and disagreement of parents were the major barriers for referral. Coming to the practice profile, most of them referred their patients for ROP screening, and they referred by either giving a discharge slip or by verbally informing the patients regarding referral. So summarizing the results, knowledge of doctors were pretty good, but there is further scope for the improvement. Attitude of pediatricians believe that ROP screening and treatment is risk-free, but more than half of the ophthalmologists believe that treatment carry risk. Disagreement of parents and non-availability of ophthalmologists were the major barriers. Coming to the practice profile, majority referred their patients for screening, and modality of referral was either verbal or by discharge slips. So concluding my talk, in our study, it was found that overall knowledge about ROP among pediatricians and ophthalmologists was good, but there is scope for betterment in attitude, referral, and screening practices. Thank you.
You are well in time. Any questions?
It's a good concept. Just as per your paper, what recommendations you would like to give?
For screening, sir?
Yeah, for all KAP, knowledge, attitude, and practice.
So regarding screening, I would like to tell that it will differ in developed countries and developing countries. So for developing countries like India, we would like to screen bigger babies actually, like compared to the developed countries. So the screening protocol should be regionalized according to me, sir. And practice profile, so everything should be according to that. That is, we can't follow some guidelines which is being followed in the developed countries, because there it has been found that ROP is found in less birth weight babies, but here in India, ROP is found in bigger babies.
Yeah, we already have these guidelines in place.
Yes, sir.
Are you aware of these Indian guidelines for
yes,
ROP
sir.
screening?
Yes, sir, I'm aware.
So what different recommendation you would like to give?
Okay,
because all these are in place.
Okay, so I would like to tell that for increasing the awareness among doctors, we can conduct more awareness programs, CMEs, and educational programs. And ROP screening should be incorporated in all parts. That is, it should be included in UG, I mean, undergraduates, postgraduates, and it should be included routinely as a part of fellowship programs also, sir. Okay. And also, we should make aware of the parents also regarding the ROP, so that timely screening is ensured from their part also.
Okay.
Any other questions?
Yes, sir.
If there's no other question, you can move to the next speaker.
Thank you, sir.
Thank you so much, Dr. Bindya. Moving on to the next presenter, I would like to welcome Dr. Diksha Katoch. Ma'am, can I request you to please come on screen?
Yes, I'm. Good morning.
Yes.
I'll just share my screen. Is my slide visible?
Yes.
Okay. So good morning, respected chairpersons. The topic of my presentation is an atypical and severe form of retinopathy of prematurity, the blister ROP. As we all know that retinopathy of prematurity is a potentially blinding vasoproliferative disease affecting the retina of premature infants and is classically described as passing through 5 stages from the demarcation line to the total retinal detachment. In addition to this classical description, we have another form of ROP, which is known to be rapidly progressive, where the absence of the typical stages has flat neovascularization and a prominent plus disease. In this study, we describe the demographic profile, clinical presentation, and treatment outcomes of an atypical and severe form of ROP in Zone 1. We did a retrospective review of clinical records of preterm infants presenting with atypical posterior configurations in Zone 1 between September 2018 to June 2020. The demographic details, morphology of presentation, and interventions done were recorded, and outcomes included progression to stage 5 ROP or regression with delineation of vascular arcades and flattening of the retina. A total of 11 infants with this pattern were included. The mean gestational age at presentation was 29.75 weeks with a range of 28 to 37 weeks. The average birth weight was 1,335 grams with a range of 900 to 2,300 grams. The mean post-conceptional age at presentation was 38 weeks. None of the infants were born in the study center. All of the infants had history of oxygen supplementation, 3 had history of sepsis, and 2 had history of blood transfusions. If you look at the morphology of the presentations, the zone of vascularization in 9 of the 11 infants was posterior zone 1, which meant that the fovea itself was not vascularized. And if the FFA was performed, it revealed a severe vascular arrest and leakage. The patterns, these are the 3 types of patterns which we encountered. The first pattern had severe vascular arrest as is seen on this fluorescein angiogram. And there was a presence of a persistent fetal vasculature stalk. And along with that, there was a peripapillary tractional retinal detachment, with sometimes the macula also pulled over towards the disc, over the disc, and leading on to a posterior closed retinal fold. The second pattern did not have a persistent fetal vasculature stalk. There was a spongy exudative detachment of the peripapillary retina in a kidney bean-shaped blister-like appearance, and there was corresponding severe vascular arrest and leakage within this spongy mass. The third presentation began typically as aggressive posterior ROP. It went on to develop nasal fibrovascular proliferation close and over to the optic disc. There was no stalk of the persistent fetal vasculature. It progressed to form an exudative detachment followed by contraction of the posterior hyaloid over the disc and a total retinal detachment. As far as the intervention and outcomes was concerned, the overall treatment success rates were low, 45.5%, and majority of the eyes, 7 out of 10, which actually regressed, had received multimodal treatment in the form of laser photocoagulation, anti-VEGF therapy, and vitreoretinal surgery. This is one of the examples of successful outcome following a combination approach including laser photocoagulation, anti-VEGF therapy, and early bilateral lens-sparing vitrectomy, all done within 2 weeks of presentation. We hypothesized that severe retinal ischemia due to vasoobliteration and capillary dropout in posterior zone 1 and breakdown of the outer blood retinal barrier leads to the initial exudative retinal detachment. There is contribution to the optic disc neovascularization by the persistent fetal vasculature. There is possibly delayed regression of the persistent fetal vasculature, and ultimately there is posterior hyaloidal contraction and a tractional retinal detachment. To conclude, an atypical morphology of ROP in heavier preterm infants is described. The proliferation arises in the optic disc region and there is rapid progression to stage 5 ROP. Combination therapy appears to offer the best chance of successful outcome. Thank you.
Were the babies monitored with red cam or just with indirect ophthalmoscope by the ophthalmologist?
So actually, we monitor with both. We do the indirect ophthalmoscopy first, and then to document this appearance, we have to do the imaging. And in this study, all the images I have shown is using the red cam.
Interventions done by a single surgeon or multiple surgeons?
So single surgeon, I have done the interventions.
Any more questions?
The laser children, Dr. Diksha, did you see any of them with very high refractive error post-op?
Yes, ma'am. The lasered in this group?
The lasered ones. Was there a difference between the lasered and the non-lasered?
Ma'am, actually, this was a presentation which was, if laser alone, most of them rapidly progressed to stage 5. So then retinoscopy was not possible because they were stage 5. In those that we had multimodality intervention, we are seeing myopia in them.
So what are the criteria when you decide laser versus anti-VEGF? Surgery is defined. Everybody knows when to do surgery.
So in this, from what we have learned from this experience of such cases is that they will be rapidly progressive. So what we do that we need to strengthen the retina. So laser photocoagulation we do right when the child presents. In the meanwhile, we know that this child is ultimately going to land up in surgery because there is already a pre-existing peripapillary tractional retinal detachment or exudative. So while the child is getting prepared for surgery, first step is laser. Then just 2 to 3 days prior to surgery, we go ahead and give anti-VEGF and then followed by bilateral. The problem is that these such cases are typically bilateral and you need to do a bilateral surgery. Then we do an bilateral surgery of the same sitting. We don't do anti-VEGF before because it may worsen and lead to a crunch.
So why I'm asking is you had a large number of patients, no? Like most of them were going into stage 5?
No, ma'am. I'm talking of just this subset with this configuration. I'm not talking of the others. And we're just talking of this subset with this profile and this type of presentation.
So any risk factors you found?
Yes, ma'am. All of them, I think it is related to the quality of neonatal care because all of them are outborn. We have not seen this in our own center, and oxygen supplementation, sepsis and anemia seem to contribute to it.
Okay, thank you. We can move to the next speaker now.
So we are done with the sessions for all the speakers.
Few are absent?
Yes,
Dr.
few are
Aruna is
absent, sir.
Can you please confirm the absentees?
Yes, ma'am. Yes, sir. So first we have Dr. Deepa Chatra.
Yes.
She's absent. Dr. Deepa Chatra.
Next page.
Next is Dr. Sahil Salgu.
Okay.
Yes. So these two and Dr. Aruna.
Aruna, someone is telling Aruna, my name is not there. It is in the chat box or something.
No, that is Dr. Ankit, sir.
Okay.
Aniket Rai.
Ask the person.
We can ask him to present. Yes, definitely. So we have two absentees. One is Dr. Deepa Chitra and Dr. Aruna.
Okay.
And if Dr. Aniket is with us, can I request you to please?
This OCTA changes in children with amblyopia. She is also absent?
Yes, absent, yes.
Okay.
Dr.
Just to confirm,
Saniti is absent.
Yeah, it's a free paper 1637 and a free paper 534. Am I right?
Yes. 1637.
1637, then 1645. Last one.
So the first one is FP534, then
Yes.
it is FP1637,
Yes.
and it is FP1645.
Okay. Three are absent.
3 are absent. Perfect.
Okay, fine.
I am not sure if Dr. Aniket Rai is with us.
But there is not in the list.
No, he's not on the list, but he just sent a message on the chat box, sir, saying his name is not in the presenters list and he wanted to present his presentation. So, but he's not here with us right now.
No, actually, then he has to talk from something chairman committee.
We'll take as per the list.
Yes, 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 sir. Yes, Santosh sir, you are correct.
Okay, so we can have discussion. We can have any more few questions.
No, we can conclude. No discussion. It's a competition section.
Okay, if there is conclusion needed.
I'd like to thank all my co-judges for conducting the session and the hall manager for time.
Thank you so much, sir.
Thank you all.
Thank you.
Thank you. Thank you, everyone.
Thank you.
Thank you, sir.
Thank you so much. We wrap this session. I was your hall coordinator, Jinal Doshi. I hope everything went on time. Thank you.